Hey guys, this is like take number 3 or 4 trying to get this recorded. I stayed up later last night to get it done and I don't even know where it went. It just got totally deleted. So anyways, I'm going to try and do all of these in one video. I do have to head to campus in a little bit. And obviously my laptop does not connect to the internet at campus, so that's why I do these at home. So I will, like I said, I'll try and put it on one video depending on time-wise. I know it took me about an hour and a half by the time I finished the entire lecture yesterday. But we will go through it, and I will also do an exam review, and I will get that recorded yet tonight. There we go. So health promotion for the reproductive health part of it, it just involves us as nurses teaching the men and the women, the younger girls, about their reproductive health, whether it's the onset of their menses or menopause or perimenopause or even amenorrhea or dysmenorrhea, as we'll get into in a little bit. Just teaches them what about their reproductive systems and what's happening. And schools actually do start teaching their kids at a younger age, but most of their education comes from their peers and what they see on the internet. I was trying to look up one day when I made these PowerPoints, what type of stuff is actually out there. And I found this picture of this young man, and he looks, I don't know, 15, 16. I'm a bad judge of character, but he looks pretty young, or bad judge of age, but he looks pretty young to me. And for him to be telling sex tips kind of blows my mind. But it was captioned, "My Hope for Young Women." And this was on YouTube. So this is obviously not a educated teaching tool that I would use in any class or for any patient teaching. So we just need to make sure that we are teaching our younger kids about this. So what are things to discuss with our young ladies? Talk to them about their cycle length, which is the first day of one menses to the first day of the next. When the younger girls' menses start, it's going to be irregular. It may be every month, it may be every 3 months, it might be every 3 weeks. So it's going to be a regular one until it gets set at its own cycle. The cycles are average 28 to 29 days, but they can range anywhere from 21 to 35. Amount of blood flow, it seems like a whole lot more, but average blood flow during a menses is 1 to 2 ounces. And it starts off heavy on the first couple days and then starts to taper off. Length of menses, generally it is 3 to 5 days, but can actually last up to 7 or 8. I do know people that have their period for really heavy for 3 days. It is completely gone and done for 1 day, and to the point where they don't even have to wear any sanitary napkins or anything like that. But then it comes back really heavy for 1 or 2 days after their day off, I guess. So it kind of depends on what the woman's body determines as their norm, their baseline. This is my little video. I like to show it. So to show the importance of really educating our younger people.
Oh my God! Daddy! 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 Daddy!
Hey, Beta, what's the matter?
Where's Daddy?
Well, he just left. What's wrong?
I'm hemorrhaging.
What do you mean you're hemorrhaging?
I don't need your help, but Daddy,
Beta,
you gotta move.
did this happen in the bathroom? How old are you?
I'm 11 and a half.
It's okay. Come on upstairs. We have to have a little talk.
My mommy and daddy did that?
Actually, a very beautiful thing. And look, there wouldn't have been a Veda.
I think it should be outlawed.
Oh, believe me, someday you'll feel differently.
Well, that's probably Thomas J. I don't want to see him. It's not fair. Nothing happens to boys. Hi, Veda. Can you come out? I don't know. Please, it's real hot. Maybe we can go swimming. No. Get out of here. And don't come back for 5 to 7 days.
That was one of my favorite movies growing up, but I think of that whenever we're talking about educating our younger ones. We need to educate them on the use of pads and tampons, but now they are really evolving into different types of protection, I guess. There's reusable pads that are, I'm not sure exactly because I haven't looked at them real closely, but what the inner material is, but the outer material is a soft cotton, and it's rewashable or reusable because you can just wring them out, wash them, whatever, and then wear them again. The little pink cup in the center picture, that's a menstrual cup. That's actually just inserted into the vagina, and the blood is collected into there. And then there is sea pearls or sea sponges. They're just placed up in the vagina and soaks up the blood and can be reused. So there's a whole lot of different types of protection that is recently evolving. Before, like I said, just used to be pads and tampons were your only options. One thing is the tampons might actually cause toxic shock syndrome, can cause vaginal irritation, itching, soreness, odor. Occurs when tampons have been inserted for too long. They can have a whole lot of complications with this. We had a young lady I was at doing clinicals, and she had been out the night before, and she had her period, and she had quite a bit to drink, and had inserted, like, I think she had 3 tampons, 2 or 3, but she had the first one from the other ones being inserted had actually went way up, and she couldn't reach it, and she had to come to the ER to get it taken out. But that's a good example of why or how easily toxic shock syndrome can happen. If she would not have known that was there, she may have, left it there for days. So really just teach them that there is issues with not changing your tampon often enough. Vaginal spray and douching, both of these are unnecessary. The douching, when a woman douches, they spray water and saline or whatever it is up into the vagina. What it does, it is actually washes the vagina out of its natural flora, and that natural flora protects the vagina against infection. So by douching, the woman is actually putting herself at higher risk for infections. The vaginal spray can actually cause rashes and more discharge and itching and burning and infections if it's used, more than very infrequently, and only external use, but it does come with its risks. Alright, now we are getting into the different disorders related to it. Amenorrhea is the absence of menses. They're not having their menses. It is primary and secondary. And primary just basically means that they have not gotten their menses. Generally by the age of 16, or if they develop breasts and within 4 years. Yeah, so if you remember, amenorrhea is amen, hallelujah, I don't have my period. That kind of helps me keep all of them straight. But amenorrhea is also a classic sign of anorexia, and what is one of the biggest risks for our teenagers? Anorexia, because of bullying. Secondary amenorrhea is the young lady has started her period, and it actually stops. I shouldn't say young lady because it can be anyone. If you think of secondary amenorrhea as pregnancy, that'll kind of help keep them all straight. But they can be caused by breastfeeding, any problem with hormones, poor nutrition, over exercising, and stress. I do have a picture down here of the American gymnastics team. These guys are, I don't want to say known because can't figure out the word I want to use. But because their training schedule is so tight and they're exercising and training for 12, 14 hours a day, they are trying to they don't always eat healthy because they're always working, and there's just a lot. And I picked gymnastics because I was a gymnast and I know more about it that way. But these girls commonly do not have a period. They will start them and then they'll get into their Olympic trainings, and because their training is so intense, they may actually stop having their period. And it has to do with the body suppressing the hypothalamus, and it's causing a low fat to lean ratio, just basically meaning they don't have enough body fat. So treatment for amenorrhea, treat the cause. So when I was giving the example of the gymnasts, or even the runners too, they might be encouraged to eat more calories. Like I have Simone here eating a cookie. Or to back off a little bit on the amount of exercise that they're doing, so maybe that their menses will return. Dysmenorrhea. This is painful menstruation. It starts the day before the menses and can actually continue to the end of the menses. So this is also defined as primary and secondary. Primary, it just basically means that the cramps are the disorder. There's no other disease that's causing the cramps. So what happens is that uterus is contracting so hard, which is the cramps, and it actually causes a decreased blood flow into that uterus, which actually causes some of those tissues to die and be oxygen deprived. So that's what's actually causing this dysmenorrhea. Sometimes it goes away after the lady's first pregnancy, but the best treatment is NSAIDs, ibuprofen, and contraceptives. Secondary dysmenorrhea, if you remember that this one is related to a disease process, whether it's endometriosis or pelvic inflammatory disorder, cervical stenosis. You can see the picture on the right with the red uteruses, drawings of the red uteruses, those are stenosis. Below that's uterine fibroids. Ovarian cysts, if anybody has ever had those, that is very, very painful. Anytime there's tumors in the pelvic area or the belly, and sometimes when there's an IUD placed, it can actually cause terrible cramping. So remember, secondary dysmenorrhea is caused by another disorder. Secondary dysmenorrhea is a symptom of something else. Primary dysmenorrhea that's the disorder. Hope that makes sense. I don't want to screw you guys up, but I'm trying to help find ways to keep them straight. So to be diagnosed with dysmenorrhea, they're going to do an ultrasound. They might do a D&C. They might do biopsy of the endometrium. And they might do an exploratory laparoscopic procedure. There we go. So treatment for secondary dysmenorrhea is basically just remove the problem, remove the cause. If they have ovarian cysts or they have fibroids, get rid of that problem, and that'll help with the cramping. They may order continuous oral contraceptives. If you guys know oral contraceptives, it's based on a 28-day schedule. So weeks 1, 2, and 3 are the actual contraceptives. But week 4 is just basically a sugar pill or a placebo. There's really nothing in that pill, and all that is a reminder. So when these ladies have this terrible dysmenorrhea where it's painful, they take weeks 1, 2, and 3, and then when they would start week 4, they would start a new pack and start at 1 week. Because that way they are never actually ovulating, and they have a continuous contraception going so that the cramps don't get as bad. PMS, premenstrual syndrome. This is just a bunch of symptoms that is correlated with the luteal phase of the menstrual cycle, which is about 2 weeks before the onset of each monthly menses, which happens to be between ovulation, or after ovulation, I should say. Symptoms that we might see or do see. The woman might be irritable. She might show signs and symptoms of depression. She might have trouble sleeping. She might be sleeping too much. She might be crying. She might have tearful episodes. She might get actually sick to her stomach, nausea, vomiting. She might be constipated. Sometimes they're going to have cravings for sweets. And their breasts might be tender. Cause is actually, for sure, cause is unknown, but they think it might be related to the levels of progesterone and estradiol. Another thing that actually affects the severity of PMS symptoms is what is that lady going through in her life. If she's got a lot of stress, then her PMS symptoms are going to be much worse than if she has, nothing really going on that she's worried about, or if she's doing pretty well at the time. So it just kind of depends on what their life events are at the time. There's the 7 dwarfs of PMS: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. So as nurses, what can we do to help manage PMS symptoms? We can teach our patients to not have a large intake of alcohol, nicotine, red meat, and foods containing sugar and salt. So some of these are kind of difficult to teach, but also they should decrease the amount of caffeine they have. So we teach them not to drink so much coffee, so much soda, and just kind of back off on the caffeine, the alcohol, the nicotine. Alright, on to the next one. Perimenopause. This is the time from normal periods up until menopause starts. It's the time where all the functions are kind of waxing and waning, and they're working and they're not working. And so it's not true menopause, but it is just that in-between time where, yes, it's working, no, it's not. The hormones are decreased, but they're not stopped, so the symptoms are starting to show up. And we need to teach our ladies that they still need to continue contraception during this time, because if they are still getting a period, they are still ovulating and they can still conceive. So Just because their period has been, they haven't had their period for 2 months, they are still ovulating. Symptoms of perimenopause. There's the symptoms of PMS. They will have hot flashes. Their periods will be irregular, like I talked about. It could be every 3 weeks or it could be every 3 months. They're going to have problems sleeping. They're going to have a decreased libido. The vagina is going to be dry because of all the hormone changes, and they're also going to have mood changes. So on to menopause. Menopause is once that menses has been stopped for a year. So they'll go through perimenopause, and then still in perimenopause, they will have, up until a year after that menses stops, that's perimenopause. After that period has stopped for a year, then that's menopause. Change of life is what it's called. Average age is 50 to 51, but it can occur late 40s, early 50s. So some people accept menopause and some people have a hard time accepting it. So whatever our patient already knows what they expect, what their family's view is on menopause, how their marriage is, and their cultural ideas. So it all kind of depends on how she accepts this menopause. Sometimes people will really view, even though, say, I'm 50 years old and I know I'm not going to have any more babies, because, or if I would go into menopause, that official menopause is the official kick in the face of, hey, you never will have any more babies. So even though I don't want another baby, it's kind of, it could be very hard for me to accept the fact that, oh, no, you can't. Everything's dried up, so you cannot have another baby. So that's part of the issue with accepting menopause. Symptoms, hot flashes. And if you go down under sleep disturbances, this little blurb is supposed to be under hot flashes. These ladies can have hot flashes 20 to 30 times a day, and some of them can last anywhere from 3 to 5 minutes. So I know some people call them hot flashes, some people call them power surges. My daughter gets them with her mast cell, and she calls them her tropical moments. She actually thinks she's off on a tropical beach. These ladies are going to have sweating, night sweats. They have problems sleeping, dizzy spells, palpitations. They're going to be weak. So what actually happens during menopause? There's a lot of organs and tissues atrophying. The endometrium, the myometrium, cervical glands, the fallopian tubes, and the ovaries, they all atrophy early on in menopause. That uterine cavity actually constricts and makes it smaller. The mucosa of the vagina is less elastic. It's thin, it's smooth, it doesn't have the rugae. The mucous membranes are not only less elastic, but they're dry, and they might burn, they might itch. And the pH levels in the vagina might increase. They're pretty alkaline, but they're going to be more acidic. So here's just kind of a little resource for you guys. So late stages of menopause, the vulva is actually going to atrophy. Pubic hair is going to thin out. There isn't going to be much left. It'll kind of fall out. The labia is going to become more pale and smaller. Pelvic muscles actually become atrophied, and the uterus can actually be what's called the uterine prolapse, where it actually comes out the opening to the vagina. So we have to watch for these muscles atrophying because they can't support all of the reproductive organs. Breasts are going to be smaller. They're going to be saggy. So some complications that occur because of menopause, the biggest one is after menopause, these ladies are at very high risk for osteoporosis because of these decreased estrogen levels. They might have less vitamin D consumption. Maybe they're not drinking milk as much. Maybe they're not out in the sun. Just kind of depends. But the little old lady who is postmenopausal and has GERD is at a very high risk, and because of the omeprazole actually takes the vitamin D and calcium out of the system and uses it. So really watch your little old ladies who are postmenopausal and taking medications for GERD, because they can be at a huge, huge, huge risk for fractures. They're at higher risk for heart problems. Wrinkling happens because there's less protein in the skin and the supportive tissues. So what used to be nice and taut is now wrinkly. And sometimes people correlate menopause with the onset of dementia, maybe the beginning phases. Some treatments for menopause. Before, when everybody went through menopause, they were just handed hormone replacement therapy, the estrogen or the estrogen progesterone concoction. But they're really kind of trying to determine if the benefits would outweigh the risks with this type of with the hormone replacement, because after everybody was on that, they realized that there's a huge risk of breast cancer, blood clots, and stroke related to the hormones. So they'll just have to determine if the benefits outweigh the risks. There's all complementary and alternative therapies. There's a whole lot of different things to do. Different types of vitamins, minerals, different types of alternative medications, acupuncture, yoga, tai chi, meditation. So there are complementary and alternative therapies out there for this. Osteoporosis related to menopause. These ladies are going to have what's called a bone mineral density test, and they may have calcium and vitamin D supplementation. They may be taking the calcium every day, the vitamin D every day. And they're going to have their meds reviewed. Like I said before, if they're on omeprazole and they're postmenopausal, they are very, very high risk for fractures. So as you can see on this picture here, it kind of shows the progression of osteoporosis. See how thin and brittle those bones are? They used to be thick and strong on the left with the green arrow, and then they're thin and brittle with the red arrow. Breast exams. There's some conflicting information. Before, we were always taught do a self-exam every month when you're in the shower. Now they're saying wait till you are having a provider visit and have a provider look. This only is because women are finding lumps and dimples and whatever, and they're rushing to get the testing done, and they're doing too much testing. But I honestly think that no testing for cancer can be too much. Anybody can get cancer. I've seen it too much recently. So just a resource for breast exams. Health promotion for women. Continuing, the mammograms depends on the woman's risk factors of how often it is. Can be used as a screening tool. It's basically just an X-ray of the soft tissues that picks up if there are any tumors or lumps or anything like that. Pap smear. This is just a sample taken from the cervix and looked at underneath the microscope. The cyto brush, as you can see here, is used and scraped at the end of the cervix, and then they look for any abnormalities Pelvic exam. This is just that visual exam of the vagina, the uterus, the ovaries, and the lower abdomen. A lot of ladies feel like these pap smears and the pelvic exams are very uncomfortable, and so they actually avoid the exam, which actually causes a bigger risk. If, maybe they've got abnormal cells on their cervix, the dysplasia, but it hasn't gone to cancer yet, so they really don't have any symptoms. If they're skipping their pelvic exam or their pap exam, those cells that are dysplasia now could be, can change into cancer within a month, and they won't know because they won't go into have their pelvic and their pap done. And that is it for that one. Let's get the next PowerPoint. Oh, let's do contraception. So this one really kind of goes through the types of contraception, but some of them, and you'll see in one of the slides that I have it in the slide, they can actually be used in reverse to become pregnant. So one of the first ways is the woman kind of monitors what her fertile window is. Generally, it's from day 8 to day 19, when the cycles are like 26 to 32 days. So it's based on their ovulation. It's 5 days before ovulation starts and 1 day after ovulation. And then natural family planning. This is just so that when they're picking out when they're fertile, depending on if they would like children or they would not at this point in time. If they don't want to become pregnant, then they'll use a barrier method, or she'll abstain from intercourse during her fertile period. Standard days method. It's just, this is for the ladies with irregular menstrual cycles where they can be predicted. And this is days 8 through 19 when she's fertile. Intercourse is avoided, or a barrier is used. Calendar rhythm method. This one is kind of confusing, but the lady records her cycles every month for 6 months, and then her fertile period is 18 days before the end of her shortest period and 11 days from the end of the longest menstrual period. Kind of difficult to understand. The Billings ovulation method. Women are instructed not to have intercourse during their first menstrual cycle. They're going to document their cervical mucus. How much is there? Is it slippery or wet, they call it? What color is it? How is it clear? And spin bark heat, if there's any spin bark heat. When you think spin bark heat, this is where if you have the cervical mucus on your fingers and you kind of stretch it out, it's kind of like the clear part of an egg. Not the egg yolk, but the other part, where it's slimy, kind of. So when the mucus is clear, elastic, and slippery, until 4 days after the last wet mucus, wet, slippery, the lady needs to either abstain or use a barrier method, because while that mucus is clear, elastic, and slippery, she'll more than likely get pregnant. It's because the sperm can swim through it a lot easier when it's that clear, when it's got spin bark heat is what it's called. Two-day method. This one is pretty simple. There's really not a whole lot of planning in part. It's based on the cervical mucus before the woman urinates. If there are secretions yesterday or today, she's fertile and she can get pregnant. If there are no secretions yesterday or today, she's not fertile today. So it's kind of an easy question, and it kind of is easier to keep track of it with something like this. Symptothermal method. This is based on the woman's symptoms and her temperature, based on her cycle days, the cervical mucus changes, increased libido, abdominal bloating, basal body temperature. I think this is the one that most people are a little more familiar with. A woman is taking her temperature every morning before she gets up, before she does anything, and it's recording it on a temperature graph. The temperature is going to drop just before she ovulates, and then it's going to raise up and stay elevated for several days afterwards. If you can see on the picture down here, you can see where her baseline is in red, and then how it's climbing up, and it dropped just before it spiked up to be where she is infertile, or fertile, yeah. So just make sure that she's using a barrier method or abstaining from the day that that temperature spikes up and for 3 days after. Yeah, I talked about that they might actually be used in reverse to become pregnant. The lifespan of sperm is 3 to 5 days, where the lifespan of an egg is only 12 to 24 hours. So it's amazing how little time frame and it still happens. Alright, so situational contraceptives. There's a lot of myth to a lot of these. The only one that is 100% effective in preventing pregnancy is abstinence. They do say that coitus interruptus, or if the male withdraws before he ejaculates, that this will prevent pregnancy. No, it is the least effective form of birth control. They also say that douching after sex prevents pregnancy. No, this is not true either. What it actually does is when the woman douches, that water, that saline or whatever, actually pushes the sperm further up into the birth canal and helps them swim along. So it's easier easier for the sperm to reach the egg. So it doesn't actually prevent pregnancy, it actually helps it along. Alright, so spermicides. Nonoxynol 9 is approved for in the U.S. It can be as a cream, a jelly, a foam, a film, a suppository. The spermicide needs to be inserted in the vagina just before intercourse. If she has suppositories, then it needs to be 30 minutes before intercourse, so that way it can melt and dissolve so that it's effective. And we're really going to teach our patients to use this spermicide with the barrier method, which we'll get into in just a little bit. Sometimes spermicides are very irritating to the skin, or the lady's may have an allergic reaction to them. The problem with spermicides is it doesn't protect against STIs or HIV or AIDS. It can actually increase a lady's chance of getting HIV because the spermicide that's injected or even on a barrier or physical barrier actually causes irritation to the vaginal wall, which can open up some capillaries, and so she can pass it along. Or so she can contract IV or HIV. I can't talk. Male condoms, most are aware of these. It's applied to the erect penis before any contact. We need to teach our patients not to use them with oil-based lubricants. Use caution with removal so that they're not breaking the condom and spilling the sperm. And this actually protects against infections decreases pelvic inflammatory disease, decreases sexual transmitted infections. So, yeah. Female condoms, they are kind of the same kind of shape as the male condom, but it's inserted into the vagina with the closed end covering the cervix. Um, the outer ring covers the woman's vulva. Can be put in place 8 hours before intercourse, but they're kind of noisy, they're expensive, and so these are kind of, and the feeling of them, I don't know if there's just not, I don't know, enough feeling or what, but that's probably why they aren't used a whole lot. Diaphragm fits over the cervix. It's not a one-size-fits-all. The provider must fit the lady for it. Must be used with spermicide, cream, or jelly, which is, so the diaphragm is actually the mechanical barrier, the physical barrier, and the spermicide is considered the chemical barrier, so that needs to be used together. Every time, or after childbirth or with weight loss or weight gain, the woman needs to be rechecked for a fitting diaphragm. As you can see in the picture, the diaphragm actually sits over that cervix, and you can see the sperm aren't able to get in. Diaphragm is inserted into the vagina just before intercourse, but it must, but the spermicide needs to be replaced every 6 hours. If it's been longer than 6 hours, and the woman is still engaging in intercourse, she needs to take it out and to put more spermicide on and put it back in place. That being said, 6 hours after intercourse, this diaphragm must be left in place. That way the woman isn't taking it out right after intercourse and allowing the sperm to reach up into where it needs to go. Vaginal sponge is kind of the same idea as the diaphragm. It's just a little pillow-shaped sponge that fits right up against the cervix. It's moistened and placed on the cervix, but it has spermicide in it. It can be worn for 24 hours, but it's another one where it needs to be left in place for 6 hours afterwards. And this is not one that needs to be fitted by a provider. They can actually, it's just a one size fits no one, I guess. Intrauterine contraception. I can't talk today. IUC, more commonly known as an IUD, an intrauterine device. These are little T-shaped devices. They're placed by the provider. Depending on what type it is, it can be left in place for 3 to 10 years. There's a huge side or risk that the lady might experience unscheduled bleeding or continuous bleeding. So this is one of the major risk factors, but it's the most common reason for the woman asking the provider to remove it. Adverse events, side effects from these, there might be discomfort, especially with placement. Sometimes the lady might experience increased flow. Sometimes those little T-shaped devices can actually perforate the uterus, cause bleeding in between periods, dysmenorrhea, and actually the device can become expelled from the uterus. The young lady, after the IUD is placed, they are going to have intermittent cramping and bleeding for at least the first 2 to 6 weeks. So anytime that she's having a late period or abnormal spotting or discharge, anytime they're having pain with intercourse or any types of signs of infection, because sometimes they can actually lodge into the side of the uterus, or if the strings are missing. There are three types. The copper IUD. This is just like I said, they're all T-shaped, but it's got copper covering on it. This one actually lasts 10 years, and it actually causes inflammation on the endometrium, which um, decreases the function of the sperm. The Mirena is one that lasts 5 years. It releases, I can't say it, Levonorgestrel, yeah. And it actually causes atrophy of the endometrium, which causes the mucus to become thick, so it's harder for that sperm to swim through it. So it's basically causing a spermicidal environment. The Skyla is shorter acting. It's only 3 years, and this does the same thing as the Mirena does. It's just this one's 3 years and the Mirena's 5 years. We talked about birth control for PMS symptoms or dysmenorrhea symptoms. These are just the oral contraceptives, estrogen, progesterone. You can see here the pills are taken weeks 1, 2, 3, and then 4th week is placebo, or sometimes people won't even take that 4th week one, and then in a week they'll just start taking. Ortho Ever patch. This patch is rotated between the buttocks, the abdomen, the trunk, and the upper arm. I do have the wrong thing here, but it's the woman must weigh less than 198 pounds, not more. They wear it for 3 weeks on and 1 week off. NuvaRing. It's just kind of a plastic, flexible ring that's inserted in the vagina. It's put in place for 3 weeks, taken out for 1, and during that, and the same with the Ortho Ever patch. When that week that the NuvaRing is out or the patch is off, is the week that they'll get their menses. Progestin only pill. These are used when the woman's got a history of blood clots, or if they're breastfeeding. This is the big one for breastfeeding, so that it doesn't cross the placenta. Or cross the placenta. Enter into the breast milk. Can't talk. Depo-Provera. This is the IM injection. Lasts for 3 months. They need to get a repeat injection every 10 to 14 weeks. This suppresses ovulation, but it can also take quite a while for fertility return after the stopping of the shot. So side effects from the Depo: menstrual irregularities. Sometimes they will have their period. Most times they do not get their menses while they're taking Depo. They may have headaches. They might have weight gain, breast tenderness, maybe some depression. But the biggest side effect is this bone demineralization. We need to encourage our patients to take calcium supplements if they're taking the Depo, to exercise. I think the cutoff date for Depo is that they can be on it for maybe 2 years. Yeah. Plan B pill. This is just a progestin-only pill. It's 2 doses. The first dose must be given within 72 hours. Second dose within 12 hours after the first dose. Sometimes the first dose is enough, but they're always told to take the second one. And this one is just over the counter. Ella is prescription only, and this one needs to be taken within 5 days of intercourse, I think the other was 3. But like I said, this one is a prescription only. Another form of emergency contraceptive, the copper IUD or IUC. If this is placed within 5 days after intercourse, it is considered a emergency contraceptive. It's probably the most expensive way to go about it, but it's also the most effective. So, operations, there are surgical sterilization, vasectomy. The vas deferens is cut on both sides of the scrotum, and it takes the male a while to become so that he cannot reproduce. It takes 4 to 6 weeks and 6 to 36 ejaculations to be effective, to get those sperm that are living already. So we need to instruct our guys and even our ladies that they need to use a form of birth control until the guy can come in and have his sperm tested, and there can be no swimmers in there. Side effects of a vasectomy: pain, infection, hematoma, sperm granulomas, and as weird as it sounds, a spontaneous reanastomosis. So where that was cut, sometimes it actually forms together on its own and becomes functional again. Tubal ligation. The fallopian tubes, they're clipped, they're ligated, they're coagulated, they're banded, or they're plugged, all using a lap procedure. If you see the first one here, it just basically says that it's cauterized, scarred, and they can tie them shut. They can just kind of put a rubber band around it. Most times these are done after childbirth, whether it is vaginal or a C-section, just because these tubes are more enlarged, they're dilated, so it's easier to find them. Complications of a tubal. If it is where they are, what's the word I want to use? Cauterized, there we go. Cauterizing it, that burns can actually transfer to the bowel. They can cause a bowel perforation, pain, infection, and hemorrhage. Those are any surgical procedures. The Assure method. This looks like barbarics to me. They really don't need an incision. Using a scope, they're going to actually go up through the vagina and up into the fallopian tubes with these little screw things here. It sits in the fallopian tube, and then the tissues start to grow into it and around it. The tissues actually block that fallopian tube in 3 months because of these little stainless steel torture devices. And that is it for that one. We're making pretty good time. Hey, we've got the STI one left. What time is it? Oh, it's only noon. We're good. Figured it would take me till about 12:30. So. Alright, STIs. There's a lot of information on these slides. So I'm going to try and condense it down into what I want you to know and what I am not too worried about you knowing. So STI used to be called STDs, but they're not really diseases, they're more infections. So it has changed to STI, the sexually transmitted infection. In the past few decades, the prevalence of these STIs has really increased. For women, it's the most common reason for outpatient visits, and adolescents and young adults make up for half of all of the STIs. And then 1 out of 4 teenagers actually have an STI, which is crazy to me. That just seems so high. It's not, but it just seems high to me. But I live in little redneck, quiet little town, Westby. I'm not going to go over these because they're all listed in here. So, trick bacteria. This is just a little protozoa that lives in an alkaline environment. This is the most common curable STI. It can be transmitted through intercourse or because indirect transmission, like on a toilet or a towel or whatever in a bathtub, from one person, transferring from one person to the next through those objects is just pretty rare. It doesn't usually happen. Symptoms, we're going to see the yellow-green, frothy, stinky discharge. The vagina and the cervix are going to be inflamed. They're going to have trouble urinating. Their vagina is going to itch. Their inner thighs actually start to itch, and they have they have painful intercourse. But the scary thing is that 70 to 85% of women actually have no symptoms. Trichomoniasis in males, they're going to have burning with urination or even ejaculation. Their urethra is going to itch, and they're going to have some discharge. To diagnose trich, those protozoas are visualized on the microscope, and leukocytes are looked for. Normal pH is usually 38 to 4, or 3.8 to 4.5, and trich generally has a pH of 5 and above. And then if the whiff test is positive, so if they put it on a slide and they smell it and it smells fishy, then that's another diagnostic. So treatment for trich is the flagell, but it's very hard on the belly, and is taken for a week, twice a day for a week. Both partners need to be treated and remain abstinent until they're both symptom-free, because otherwise they're just going to continue to reinfect each other. There is also a tinidazole. Can't say some of these meds. It's just given as a single dose, but it's more expensive, but it has a lot less GI effects. Women that come down with trich, they can actually be at higher risk for rupture of membranes, preterm birth, or low birth weights. Alright, on to chlamydia. This is the most frequently reported STI in the U.S. Generally, it's patients under 25, and this is transmitted through intercourse. Symptoms, they're going to have a thin, purulent discharge from the vagina or the penis. They're going to have burning in frequency when they're urinating. They're going to have a friable cervix, which is basically it's irritated, it's nasty, it's angry, and painful. They're going to have some lower abdominal pain. But another scary thing is 75% of women and 50% of men actually do not have any symptoms, but they still carry the infection. Diagnosis. This is just a lot of testing. I don't want you guys to get too caught up in that, but do know that a lot of times the chlamydia is caught is noted when a male is being treated for, it's called NGU, non-gonococcal urethritis. Basically means it's not related to gonorrhea. So just know that this is when it's commonly diagnosed. Treatment, they're going to give Zithromax and doxycycline together, except for if they're pregnant. Again, both partners need to be treated and no intercourse for 7 days or during the course of the antibiotic. Chlamydia actually may cause that non-gonococcal urethritis. When we get into gonorrhea, it'll make a little bit more sense. I should probably switch those slides around. But even chlamydia causes an increased risk of getting HIV and AIDS. Risks in females, infertility, ectopic pregnancy, increased risk of HIV, and pelvic inflammatory disease. During pregnancy, if you look at this little baby, he's got ophthalmia neonatorium, which also can lead into blindness. So that's why we put that erythromycin eye ointment at birth, is if mom by some chance has an infection that we haven't caught before labor delivery, we want to just make sure that baby's protected. If mom does have chlamydia, baby can actually acquire what's called chlamydia pneumonia. Gonorrhea is another huge younger generation. 3 out of 4 are less than 30 years old. 3 out of 4 cases of gonorrhea are less than 30 years old. And I will tell you, it's called the clap, but it was started way back, long time ago, probably medieval days, I guess. I don't really know exactly when. But when they were first diagnosing it, when it was coming around, they thought that you could cure it by clapping your hands on the penis, and that would clear up the gonorrhea. But that's where the clap came from. Symptoms. Women are going to have this purulent green-yellow vaginal discharge. They're going to have troubles peeing. They're going to have frequency peeing. The vulva is going to be inflamed. The cervix is going to be inflamed. The discharge is going to be foul smelling, but they may also be asymptomatic. Males, they're going to have urethritis. This is a cardinal symptom of gonorrhea. It's just inflammation of the urethra, but they're going to have burning with urination from this, and there's going to be yellow-green discharge from the urethra, from the tip of their penis. But just remember that the urethritis is a cardinal symptom of gonorrhea. Diagnosis, they're just going to do a swab culture. Treatment, they're going to get Zithromax and Rocephin together because a lot of times gonorrhea and chlamydia live together, and that way they're just they're treating both disease or both infections. Gonorrhea, risks of gonorrhea infection in the females, obviously it's pelvic inflammatory disease. If the woman gets gonorrhea after her 3rd month of pregnancy, that mucus plug is going to protect that baby so the infection won't reach the baby, but it will, the baby will be protected. Sorry. Gonorrhea, same thing, ophthalmia neonatorium, and the erythromycin is given. Complications of gonorrhea, body infections are going to occur more frequently, and they're going to become worse. Heart disease, arthritis, blindness, and the person might actually become sterile from gonorrhea. Herpes, there are 2 types. Type 1 is the cold sore, and type 2 is the genital sores. You can have a type 1 on your genitals. Just kind of depends on where it originates. Herpes is not curable, but the symptoms can be treated. Our patients are going to have exacerbations or flare-ups of the lesions. Basically, when a person becomes stressed out, I think we've got a slide here. Yep. Oh, yeah, there we go. Primary outbreak. These blisters are going to occur on the penis and the anal area in males, and the genitals, the vaginal walls, the cervix, the urethra, and the anus in females. So all in the reproductive areas. Can happen within a couple hours or up to 20 days after exposure. And these blisters might actually rupture, and these lesions are going to be very, very painful. It's going to be kind of like, basically it's a cold sore on the genitals. So you can imagine that urination is going to be very painful with this. Lymph nodes are going to be enlarged. The patient might kind of feel fluish, and they're going to have itching of their genitals. Once these primary lesions heal, can take 2 to 4 weeks. The virus is going to stay in the person's body, so that way when they get stressed out, or sometimes with menstruation or ovulation or even pregnancy, the herpes will resurface again. If they're having frequent vigorous intercourse, or they have a poor health status, they're wearing clothing that's too tight, or they're getting too hot. Those are all things that will cause exacerbation of the herpes and cause the lesions to return. Diagnosis, um, the provider's going to look at all the lesions. They may take a culture. They may use the PCR identification. So treatment for herpes, after first outbreak, daily or with other with the outbreaks when they happen. So they need to take, sorry, I'm trying to do too many things at once. They need to take the antiviral. Some people take it all the time, 100% of the time. Some people just start taking it when they start feeling an outbreak coming on. They need to make sure that their vaginal or their the penis area is clean and dry, making sure they're wearing loose clothing, cotton underwear. And any women that has lesions present while they are going to be giving birth, they'll need a C-section. On to syphilis. This is transmitted vaginal, oral, anal intercourse. Classified actually in primary, secondary, and tertiary stages. So primary stage is syphilis. There's a little canker like you can see up there on the picture up there at the site of infection. And the person is going to have like slight fever, weight loss, and fatigue. So basically some kind of flu-like symptoms with a little canker. This can last about 4 weeks and then it'll disappear. Secondary stage occurs at 6 weeks to 6 months later. And these wart-like plaques occur on the vulva, and they get a rash on the palms of their hands and the soles of their feet. Syphilis can lead into arthritis and all sorts of other inflammations, iritis, sore throat, hoarseness. The tertiary stage, the late stage, this is like when it hasn't been treated for a long, long time. It's going to go into neurological problems, visual problems, deafness, stroke, dementia, heart disease. So it can be a very, very, very fatal disease. This is just a little resource for you guys. These are just some pictures of symptoms. The diagnosis of syphilis is basically done under microscope. It might be like the dark field exam, looking for the little curly cues of it. The VDRL test or the RPR, or yeah. Treatment, if it is less than a year, they're going to get benzathine penicillin G, 1 dose. If it's longer than a year that they've had this, then they're going to get 3 doses. Venereal warts, also called condylomata acuminata. This is caused by the HPV virus. There are 100 strains of HPV, and 40 of them are directly affecting the genital tract. The high-risk strains of HIV can cause a cervical cancer, but the low-risk strains actually cause the genital warts. Risk factors, if the person has multiple partners or history of STIs. Sometimes the immune system can actually cause the HPV to not cause any damage, but they can, or like any visual damage of the, the wart-like plaques. But the cervix can actually start changing into cancerous or precancerous cells. This will happen slowly. And if they see any risk for cancerous or precancerous cells, they're going to want to do a colposcopy, which is just a closer look into the area. Symptoms. There's going to be one or multiple lesions that actually look like a cauliflower on the genitals. It's going to itch, it's going to burn. Intercourse is going to be painful, but it can be incubated for 3 weeks to 3 years. So it doesn't always happen right away. Ointment or treatment for warts, there's just different topical solutions to put on there, but there are the preventative, the vaccines, the Gardasil vaccine, which is a quadrivalent vaccine, so it's effective against 4 types of HPV. The Cervarix vaccine is a bivalent vaccine, so it's effective against 2. And I want to say that one of the students told me that because she works in peds, so where they give it the most, that there is one that is effective against 12 or 13. HIV and AIDS. This is transferred by blood, semen, or vaginal secretions. The HIV is going to attack the immune system, and their weakened immune system because of the HIV. They don't actually pass away from AIDS, but they will pass away from any opportunistic infection or whatever can attack the immune system. They get Kaposi sarcoma pretty easy. So yeah, it's not that they die of HIV or AIDS. It's the fact that they die from something that's caused complications. Bodies know at the end stage they're not allowed to or able to fight off any infections. They're common to the HIV actually makes it easy for them to pick up the pneumonia, and a lot of people do pass away from pneumonia as well. Symptoms, 2 to 6 weeks after they are infected, they might have some flu-like symptoms, the swollen lymph nodes, the diarrhea, fever, weight loss, shortness of breath, cough. So really not a whole lot of anything other than, hey, I don't feel so hot. But the problem is that even when they're not feeling so hot and not realizing that this is HIV, these people can still pass this on. So treatment for HIV and AIDS are antivirals. An example is the AZT. So it doesn't cure AIDS or HIV, but what it does is it slows down that virus. It slows the progression of HIV going into AIDS. And that's it. We made it through. If you guys have any other questions, let me know. I am heading up to campus right now, and I will do the exam review this evening. I will tell you guys though, if you guys see this today, I do have to run and meet some people at the haunted house and get some finishing touches on but I will come back, and it'll be later this evening that I will get it recorded. So again, if you have any questions, please let me know. I know I've been kind of running around all over the place and not really being exactly as accessible as I would like. But so let me know if you have any questions. All right, have a good one, guys.